Baclofen is another drug that can alter muscular contraction. It induces skeletal muscular relaxation and so has been useful for treating spasticity. Now take a look at the GABA molecule. Compare the backbone here to the backbone of baclofen. They are the same with the exception that baclofen has this side group. Thus, it shouldn't be surprising that baclofen acts at the GABA B receptor. These receptors exist in the spinal cord. Now look out for baclofen to be used as treatment after spinal cord injuries as well as for muscle spasms and to treat multiple sclerosis. Cyclobenzaprine is a drug that can be used to treat muscle spasms as well as pain associated with musculoskeletal conditions. Importantly, unlike some of the other drugs we discussed, such as baclofen, this is typically used for spasms that do not result from neurological conditions like cerebral palsy, for example. So, if you get a question where a patient has muscle spasms, but the cause is neurological, then cyclobenzaprine is not the answer. One other fact you should know is about the side effects of cyclobenzaprine. You may notice that the molecular structure of cyclobenzaprine is similar to that of TCA. So, using this as a clue, what would you expect the side effects to be? Well, TCA is an antidepressant that you should definitely know the side effects for. The side effects are typically thought to be related to its anti-muscarinic activity. So, using that as a clue, what would the side effects be? You should see drowsiness, dry mouth, dizziness, and blurred vision. Parkinson's disease is a progressive neurodegenerative movement disorder caused by a loss of dopaminergic neurons in the substantia nigra, which is shown here with this red mark. You'll recall that the cardinal symptoms we talked about are tremor, bradykinesia, rigidity, and postural instability. These symptoms can be controlled primarily by increasing the net effect of dopamine in the CNS. There are several ways we can try to accomplish this increase of dopamine. First, we can just add dopamine agonists right at the receptor. Second, we can just try to increase the amount of dopamine in the CNS period. And then third, we can decrease the breakdown of dopamine so that the dopamine that is at the synapse stays there for a longer period of time. The fourth method has a few more steps. Dopaminergic neurons normally inhibit the release of acetylcholine from the striatum. Now in Parkinson's disease, these neurons are lost, and so there is an increase of muscarinic activity. Benzotropine is an anti-muscarinic drug with CNS penetrance, so it is efficacious in PD. It improves both the tremor as well as the rigidity. However, it does not improve bradykinesia. Why is that? Well, that is because the bradykinesia is the result of decreased dopamine and not the result of the increased cholinergic action. Keep in mind that in a prompt describing a patient with tremor, it may not always be PD. For a question, you want to look for other signs of Parkinson's disease. Essential tremors and familial tremors are usually isolated and are not associated with bradykinesia or gait abnormalities. For those tremors, non-selective beta blockers are used. Okay, time for another flash quiz. The question here is, how do local anesthetics preferentially affect pain sensation? So you should remember that local anesthetics work by blocking the smaller diameter myelinated fibers first. This means that C and A delta fibers, which are the pain fibers, will be the first fibers blocked. Also remember that A delta are fast pain fibers while the C fibers are the slow pain fibers. The combination drug of Levodopa and Carbidopa is the most effective treatment we have for Parkinson's disease. L-dopa is a dopamine analog. It's an oral agent, and so it's absorbed through the GI tract and it has to enter the brain through the bloodstream. However, L-dopa itself is readily metabolized by peripheral tissues, so in order to increase the availability to the brain, it is administered with carbidopa. Carbidopa acts to inhibit the enzyme aromatic L-amino acid decarboxylase, which converts L-dopa to dopamine. Carbidopa itself does not cross the blood-brain barrier, so only L-dopa is delivered to the brain, crosses the barrier, and is converted within the brain to dopamine. The side effects are mainly GI upset as well as arrhythmias. The drug combination is for symptomatic management only. It does not have an effect on the course of disease. In fact, as disease progresses, the duration of therapeutic activity gained from each dose decreases. This is termed the wearing off effect, and it usually starts after 3 to 5 years of L-dopa carbidopa therapy. The dose of levodopa will improve mobility for maybe 1 or 2 hours, but then the rigidity and akinesia will return, and in later stages of disease, patients have what's often referred to as on-off phenomenon. This means that they rapidly fluctuate between being off, where the medications aren't helping at all, and then rapidly switching to being on, where the medication is helping, but they also have these disabling dyskinesias. In addition, patients frequently will develop dystonias. As you can already see, Parkinson's disease is an extremely difficult disease to treat. Selegiline is a drug that is also used for Parkinson's disease. Now in the brain, dopamine is broken down by MAO enzymes. And it's broken down into 3,4-dihydroxyphenylacetic acid, which is a lot to say, so we're just going to call it DOPAC. Selegiline inhibits the MAO-B enzymes, which thereby increases the effect of dopamine by allowing it to stay around at higher levels. You should recognize that this MAO inhibitor is different from the MAO inhibitors used to treat depression, which act primarily on norepinephrine and serotonin. Selegiline has been shown to enhance the clinical response to L-dopa, and so it's used as an adjunctive therapy. When it is used alone, there's only modest effect on symptom relief. The side effects from this drug include nausea as well as orthostatic hypotension. Alzheimer's disease is another neurodegenerative disorder which we discussed in detail during the pathology lectures. NMDA excitability is known to cause brain damage and is thought to be at least some part of the pathogenesis of AD. Memantine is one of the drugs used to treat Alzheimer, and it is actually a non-competitive antagonist at the NMDA receptor. This leads to a reduction in excitotoxicity. The most pronounced degeneration occurs in acetylcholine projections to the cortex. And this is the rationale for using acetylcholinesterase inhibitors. Donepezil is the most widely used of the 3 available drugs. The drugs are generally quite safe, but unfortunately they are not all that effective. They don't change the course of disease, though in some patients they may slow the progression and are thus widely used. Huntington's is a genetic disease, and at this point only symptomatic treatment is available. No drugs can actually slow the progression of disease. Now, not all patients with Huntington's disease need to be treated, only when the movement disorder is so bad that it causes danger to the patient or to others, such as falls or injury, then drug therapy must be considered. Now, as you know, it is caused by a loss of the striatal nuclei, and therefore a loss of inhibition in the CNS. So one way to think about this disorder is in terms of dopamine's role in movement. We've discussed that dopamine is involved in the initiation of movement, which is why a lack of dopamine leads to Parkinson's disease. Now, in Huntington, there is too much movement, thus one way to fix this problem is to decrease dopaminergic action. Tetrabenazine and reserpine deplete dopamine in the CNS, so they may be helpful. When you prescribe these drugs, you want to monitor for hypotension as well as depression.
Haloperidol or Haldol can also be used. This is a typical antipsychotic that blocks the dopaminergic receptor in the nigrostriatal pathways. Lastly, we'll mention the triptans, of which the most common example is sumatriptan. This is a very effective drug used for acute migraines as well as cluster headaches. It is a serotonin 1B, 1D agonist and is available as a nasal spray as well as in pill form. Now, the reason that I have serotonin here is so that you can see the similarity between the structure of both of these, and so it makes sense that sumatriptan can act as a serotonin agonist. Remember to be careful using this drug in older patients with coronary artery disease because it can cause vasospasm.
Okay, time to test yourself. So the first question, a 25-year-old day laborer on a fruit farm is brought to the emergency department by a coworker because he is having diarrhea and difficulty breathing after their lunch break. His heart rate is 50, blood pressure is 200 over 100, and his respiratory rate is 23. His temperature is 98.4 degrees Fahrenheit. On examination, he is diaphoretic, drooling, and unable to answer questions coherently. What should the physician give him to treat this condition? Maybe you should give him a recommendation for a better place to eat lunch. Maybe that's the key. The answer here is pralidoxime. This question requires you to make a few steps before getting to the answer. As a general rule, when the boards gives you very specific information about a patient's occupational, social, or family history, this information is likely to be important in terms of guiding you in answering the question. In this case, we are told that the patient is a day laborer on a fruit farm. This is the first clue. Next, they gave a list of symptoms that are associated with increased cholinergic drive. Given these two pieces of information, it is likely that the patient is suffering from organophosphate poisoning. Organophosphates are acetylcholinesterase inhibitors, and thus they lead to increased cholinergic drive, which you can see by things like diaphoresis and drooling. Now, it's very important to know the treatment for common overdoses or poisonings. In this case, we should give pralidoxime because it regenerates acetylcholinesterase. It does this by binding to the poison. Dantrolene is used to treat malignant hyperthermia, as well as neuroleptic malignant syndrome through preventing the release of calcium. We discussed that. Physostigmine is an acetylcholinesterase inhibitor itself and would only worsen organophosphate poisoning. Lastly, succinylcholine is a neuromuscular blocking agent that is potentiated in the presence of acetylcholinesterase inhibitors and would not be used in this case. A 24-year-old woman is brought to the emergency department by her husband after she accidentally overdosed on her anti-seizure medication. Her husband cannot recall the name of the medication. The patient's medical history includes a recent abortion of a fetus with spina bifida. On physical examination, the patient is an overweight, extremely lethargic woman displaying bilateral hand tremors. She appears confused and is oriented only to self. What abnormality might this patient have as a result of her medication toxicity? This can definitely be a tough one. The correct answer here is elevated liver transaminases. Let's see how we get to this. The first thing that you need to figure out is the medication that the patient has overdosed on. You know that it is an anti-seizure medication, and the first clue is that she has a medical history of a fetus with spina bifida. There's something that connects anti-seizure medication and a fetus with spina bifida. You should know that this is a neural tube defect that can occur due to the teratogenic nature of valproic acid. The second clue that this is valproic acid is that the woman is overweight. Weight gain is a common side effect of valproic acid. Lastly, the patient is displaying symptoms of valproic acid toxicity. So now let's go to the answer choices. An increased neutrophil count is actually the opposite of what we would see in valproic acid toxicity, because it usually leads to agranulocytosis and thrombocytopenia. you are more likely to see a low serum pH with valproic acid toxicity because it often leads to respiratory depression, which can lead to acidosis. Lastly, valproic acid is unlikely to affect the kidneys. If it did, one would expect an increase in serum creatinine rather than a decrease. Okay, so there you have it. We have gone through a lot of material that is important for you to know. Neuro is what I like to call a high-yield section, and that's why they got me to teach it. Now I say this because although there's a lot of information, if you apply yourself and really learn the things you need to know, you will be able to answer a lot of questions correctly. Most of the neuro questions actually won't be tricky. They will just require that you did the groundwork. So, do the groundwork. And remember, confidence is just as important as the knowledge, so do everything you need to make sure you're confident when you walk in on test day. Good luck. May the force be with you.